Good morning, ladies and gentlemen. Allow me to congratulate the organizers on the organization. Now the floor will go to Mr. Grigorakis, who is an endocrinologist and who will touch upon the reasons why, the medical reasons why, a mother can't breastfeed.
Καλημέρα σε όλους. Πριν αρχίσω θα ήθελα...
Good morning, ladies and gentlemen. Allow me to start by thanking the organizing committee for the invitation to participate in the conference, and especially Mr. Nikos Varakis for the constant contacts that we have had in order to organize everything. I will also be as quick as possible, and I will touch upon the boring facts following Mr. Newman's presentation. Well, I believe that everything has been said. I don't know if there is much more for me to say, but anyway, there are some new theories that I believe are still valuable, and there are some new things about the problems that may be there when having difficulty in breastfeeding. Allow me to say that I serve no specific purpose here. I mean, I do not represent any companies. I'm here for three reasons. The first reason is of a scientific nature. I have been dealing with the issue of breastfeeding, and I realized that endocrinologists are absent from breastfeeding. And breastfeeding is an issue of endocrinology. The hormones involved are plenty, and the role is of paramount importance in breastfeeding. And I really don't know why endocrinologists haven't yet dealt with breastfeeding. So this is a whole new area to explore. The second reason is my personal experience. 3 children, more than 90 months of breastfeeding, 3 perfectly healthy children who only took antibiotics once in their life. And that struck me. And the third reason why I'm here is, because it's difficult to live with a IBCLC, and I'm here to provide an answer, and I'm sure many of you know exactly what I mean. I'd like to share a few awkward truths. Mr. Robert Lasting, has inspired me. So, breastfeeding is nutrition at the beginning of life. There is no financial interest from breastfeeding. However, the contrary is probably true. The industry of milk has conducted a lot of research. The genome-wide associate studies, that methodology, led to many interesting discoveries in the genes, about the genes involved in breastfeeding. Some genetic modifications that take place. You can't correct a health system if you don't correct and redress health to start with, and you can't correct health if you don't correct nutrition and food. So, breastfeeding is of paramount importance in general. And if we take the example of animals, we will realize that there are 3,500 mammals. If mammals were not able to breastfeed, then they would have gone extinct. And it is indicative to say that less than 1 out of 1,000 cows finds it impossible to breastfeed. So why has the human being made breastfeeding such a difficult task? Let us try to discover what is the reality and what do we need to do to overcome problems. More than 75% of new mothers in the U.S. wish to breastfeed, and this is contrary to what happened in previous years. Now, the number of women wanting to breastfeed has increased. Out of this 75%, only 40 or 50% in the US and 60 to 90% in the rest of the world complain for breastfeeding, about breastfeeding deficiency, and they stop at 6 months. But the objective reasons for that deficiency are very few. So there are many gaps that we need to bridge, and there is a lot of room for improvement. When women say that there is a breastfeeding deficiency, women say, I don't have much milk, it just doesn't go down. Maybe this defers lactogenesis, and it reduces the quantity of milk and the duration of breastfeeding. Sometimes women do not ask for help, they are disappointed and tired and they stop. Or they ask for help, but they are misled or guided wrongly, and they have to stop because they have been guided wrongly. And so how can a woman not be able to breastfeed? If we have women who are transgender women and they are able to breastfeed, and how can't mothers breastfeed when adoptive mothers can breastfeed, according to recent studies of 2018? So, if certain categories of women can breastfeed, why is it then so difficult to convince biological mothers that they can indeed breastfeed? What are the reasons? Medical intervention is one of the reasons. Let us not deny, let us not hide it. Gynecologists, endocrinologists, pediatricians, doctors involved in breastfeeding have some wrong beliefs, and they are in a hurry to stop breastfeeding. Sometimes they believe that the woman doesn't have milk, but the milk is there. It's just that the baby can't have it. So, medical intervention is the first reason for lactation deficiency. There are three categories within the framework of which we have some difficulties: genetical reasons, some disorders in with prolactin, and some other intracellular routes and paths that, and we may have some disorders there, and we have disorders in in conveying the right messages, and other problems relating to the production of milk. There are some factors that can be modified. With the right support, the mother, the woman, can continue breastfeeding, lactation. And this has to do with endocrinology and the physiology of lactation.
Υπάρχει δυνατότητα να προβλέψει κάποιος που ασχολείται με το θυλασμό.
So, if a woman is not in the position to breastfeed, then she will be faced with problems. There are some indices, some indicators which have not yet been sufficiently studied, such as the increase of nitrogen and of lysozyme. So, the diagnosis, anyway, is something that you have to do. You are the experts. I leave that to you. I would like to embark upon a conversation, a discussion with you, with my presentation. I'd like to convey the following message. It's different to describe the physiology and the pathophysiology of breastfeeding, and then a totally different thing to be able to judge whether a neonate is in the position to breastfeed or not. What's the objective in general? Breastfeeding is physiological and natural function. It is not complicated, and there are no women who can't breastfeed if they were pregnant. There are some difficulties which can be explained through medical or endocrinological reasons, and there can be some kind of prevention for the mothers, and this is what we as doctors have to do. But maybe there can be a more justified solution, and this is, of course, your work. Speaking about the reason, the medical reasons that have to do with breastfeeding disorders, well, they are divided into several categories. We will be talking about the biological, systematic, medical issues and problems, some chronic disorders of the mother or illnesses, some mental illnesses, and so on and so forth. When we talk about successful breastfeeding, what do we mean? We mean a good cooperation, a proper cooperation of cellular, molecular, and biochemical characteristics and phenomena which lead to the proper production and secretion of milk. All this system, the system is managed by reproduction hormones and other hormones. Let's see the hormones that are involved in the process of lactation or breastfeeding. They cover a wide spectrum of things from the moment after birth, when breastfeeding starts, till the end. And you see the role played by all hormones, prolactin, insulin, estrogens, growth hormone, cortisol, thyroxine, leptin, serotonin, and other hormones that are not on my slide. We will be talking about prolactin, insulin, and thyroxine, however, and the disorders are associated with them. Prolactin and oxytocin and estrogens and the placental galactogen. There are some specific characteristics, and it is indeed very, very complex to study the pathophysiology of breastfeeding. When we have low insulin, then there is a problem with breastfeeding. But even when insulin is high, then we have problems with breastfeeding. If we have increased cortisol, we have problems, but the same applies to low cortisol. If there is hyperthyroidism, then there is a problem. If there is hypothyroidism, there is a problem. So we see that there is a very subtle balance with hormones, and this is what we have to study. Let's shift to a first important question. We see the breasts, they look normal. We have difficulties with breastfeeding, some disorders with menses. What could this mean? What could the diagnosis be? This could be the ovary syndrome, the polycystic ovary syndrome, which is very frequent in Greece. The souther we move, the more we see it. So what is this polycystic ovary syndrome? Three criteria. Anovulating menses, some hyperandrogenemia, increased androgens, and cysts, ovary cysts. These are some of the main reasons. The most important factor of subfertility or infertility is the polycystic ovary syndrome, which is part of the metabolic syndrome. And this is a very important element for you to remember, because it plays an important role in breastfeeding. Here we have some pictures of women women with the polycystic ovary syndrome. We see non-well-developed breasts, but this is very typical with that syndrome. Let's move to the second question. What are the common characteristics between obesity, the syndrome we've spoken about, diabetes, and pregnancy in higher age groups? We have a late onset of lactogenesis and an early stop of breastfeeding, end of breastfeeding, because of the issues of the metabolic syndrome. Hyperinsulinemia is what is the main characteristic of the metabolic syndrome. I have to talk a bit more about the metabolic syndrome, I believe. It is a disorder with multiple expressions, with a varied clinical, if I may say so, expression, and it is based on insulin. We see the pancreas, and we see how the sugar is metabolized. When insulin can't act, then the sugar cannot be metabolized. Insulin is constantly increased. We have hyperinsulinemia, and this is how the metabolic syndrome is caused. And it is a plague. It is a very frequent phenomenon. Lots of money, rather high amounts of money spent in fighting against the metabolic syndrome. And we have some other problems, such as, for example, the non-alcoholic fatty liver disease, dyslipidemia, and other cancer and other issues. So, the mothers from healthy, they start having difficulty in metabolizing sugars. Then we have disorders with glucose. This is a pro-diabetes phase. And then we move to diabetes, real diabetes. And this leads to obesity, the polycystic ovarian syndrome, then pregnancy in higher age groups, and an increased weight of the neonate. And all the problems associated with that. What is the common characteristic? Hyperinsulinemia. There is a gene which is expressed in the cells of the breast, and this gene obstructs the action of insulin. And if we will be able to measure it properly, if we measure this indicator properly in the future, then we will be able to solve many more problems. So insulin is both necessary, is necessary for the differentiation of the breast during pregnancy and for the proper production of milk later. Insulin is of paramount importance in general. It is important for the differentiation, rather, of the breast. We have receptor A and B of insulin, and we see that receptor A is high when we have differentiation and cellular development till the middle of pregnancy, if I may say so, and then we have the receptor B increasing with the synthesis of lipids, and we have this alternation of receptors during breastfeeding. Insulin may reduce the levels of prolactin when the child when the child is suckling, when the neonate is suckling. But resistance to insulin is not only manifested during pregnancy and breastfeeding. it is probably there before, even before, since the first stages of breast development. And this study, which was conducted in Norway, shows that the weight of a woman before gestation, before pregnancy, greatly influences the whole process and breastfeeding. And how do we deal with this metabolic syndrome before breastfeeding? We have to lower insulin by lowering sugar and the carbohydrates with the help of exercise and eating real food. And we shouldn't aim at fat. Fat is not the issue. Carbohydrates are the problem, and especially the processed ones. So how do we deal with such problem in breastfeeding? By lowering cortisol, which is the stress hormone, through a skin-to-skin contact. That's very, very important for you to remember in order to fight insulin resistance. Glucophage can lower insulin levels. The results are not very convincing, however, not yet at least. So we're still trying to decide whether we should provide glucophage instead of insulin, and if we could use it during breastfeeding in order to promote a more successful breastfeeding process. However, in order to increase milk, you usually use supplements Galega officialis, gal, which is milk, and ega, which is the goat in Greek, which comprise metformin, which is the substance of the medicine, and the same applies to perfugreek, the ferrogreek. So the decrease of the insulin level may greatly influence breastfeeding. And insulin resistance is a growing problem, especially in Western societies. Women in the U.S. from 20 to 24 years of age have an issue of pre-diabetes, and they have a late onset of lactogenesis.
Ως τώρα η αύξηση του σαχαροδιαβήτου είναι 700%. Η παχυσαρκία τότε ήταν 1/7, τώρα είναι 1/3, το 2050 θα είναι 1/2. Το 1980 ο σαχαροδιαβήτης τύπου 2 στα παιδιά ήταν 0. Το 2000 1/10, είχαν προ ή σαχαροδιαβήτη και έφηβοι 1/4. Καταλαβαίνετε τι περιμένει στο μέλλον τις γυναίκες οι οποίες θα είναι υπέρβαρες ή παχύσαρκες. Όσον αφορά το κομμάτι που μας ενδιαφέρει αυτή τη στιγμή, το θυλασμό.
As far as we are concerned, we need to understand that if we don't manage to give the appropriate guidelines, we shall suffer even more in the future with diabetes mellitus. So, by proposing the following scheme, what actually affects the whole process of lactation, we see that there is a problem with oxytocin and, of course, with prolactin. So, insulin itself, through its secretion, affects lactation, but of course we also see that breastfeeding might also decrease the levels of insulin. So as much as breastfeeding is concerned, we see that the insulin resistance is affected. So we see that there is an vice versa relationship. Now, some other hormones that affect lactation, thyroid and lactation. Of course they do affect, but this will be discussed in my speech tomorrow. Now, hypophysis is the most important gland of our hand. It's behind our nose. It is offers eight important hormones. You see the two lobes, the frontal and the anterophal. You see the 6 hormones, and you can see that where prolactin is produced, and we see the other two OXT is actually produced. But of course, we also the GH hormone, whereas the others, if of course you don't have them, you cannot fall pregnant. So we see that the problems in the hypophysis, we see some of the syndromes. You see the lymphocellular hypophysitis, where we see an attack of the system itself, where we see there's a problem with the frontal lobe, the Sheehan syndrome after a difficult pregnancy, and of course the hypophysis deficiency. So we'll have adenum. So in this case, we might have a destruction of the GD hormone. I need to say that this is rather rare. It is not one of the other hormones that are disrupted, but still it might happen. Now you can see the Sheehan syndrome in the CT scan. So can we actually administer PRL or OXT, so in other words, in forms of medicine? Yes, we can. And it seems that it has a good factor, but who is actually producing? It is not produced, it's difficult to be found. But still, it is one of the solutions, the administration of these hormones. Now, let us see another factor which might affect lactation, and this is the different environment in which we live. We see the pesticides, the so-called endocrine disruptors, which might create problems in breastfeeding or lactation itself. I'm not saying what it might be transmitted in the milk itself, which is minimal, but especially how the whole process of lactation is or might be affected. So how it can be affected? Well, the lactogenesis is retarded, and we see that they have an estrogenous and androgenous factor. And of course, they might also create a problem in the hormonal environment. Still, a breast is a beautiful organ which can protect the embryo, especially from cadmium, this heavy metal. Moreover, cadmium, which is very low in the milk, it is very low quantity. So it is a mechanism of protecting the embryo. But of course, the benefits for the over IQ, of course, create a positive outcome to the newborn itself. Just in a very brief slide, you might see some other problems that do not play an important role. Of course, drugs, we can continue having breastfeeding, infections, mastitis, or any other, the general anesthesia. Yes, we can continue breastfeed. Whether we need all anesthetics in today's environment can be utilized in terms of breastfeeding. In mammography, why should we have mammography? That's a question. There's some other different methodologies. New pregnancy, of course, lactation can be continued, and of course, we can also continue breastfeeding even if we have a breast surgery, plastic breast surgery. Now, all of these list of different illnesses of child cannot affect the whole process of breastfeeding. And for particular cases, in cases of HIV, well, there's an open question. Some people tend to say that we should stop breastfeeding, some others not. Well, it seems initially that through the antiretroviral therapy, the treatment can be continued. The most adverse effect could be to have, let's say, a ratio between breastfeeding and, of course, formula substitution. So we can have such an analogy, such a ratio. Previously, in one of the videos of Newman, we saw a woman who had these white parts on her nipples, the so-called Raynaud syndrome. This is a secondary problem. The Raynaud syndrome is an autoimmune disease that has a problem with hematosis of hand in hand, and it can happen also in nipples, and this creates a large pain. And as I said, we should also avoid any other surgical impact, because this we might have in the prolactin and it might be decreased. And of course, cesarean section is another issue that is, I don't know, sometimes beyond any discussion. Now, my concluding remarks. Now, the knowledge of pathophysiology and of lactation might offer the prevention of problems. Now, the solution to different issues of the quality and quantity of lactation mainly is related to the consultation of specialists. And finally, we need to say that we need to have absolutely a synergy between specialists who will actually help get the best possible result out of the lactation process. Now, I wanted to add this slide because I want to say why people do not deal with this topic. Well, I wanted to find why sometimes we do not deal with this issue. Now, there's a group of scientists and physicians who say that we're dealing with a special gland. It has some particular hormones, and we need to see them in a different perspective. It is a generalized indifference why we don't want to talk about lactation. People say, yeah, that's not that bad for a woman not to breastfeed. Some other people, because they don't understand what are the consequences on human health. Some others tend to believe that we cannot have such studies. Yes, indeed, but we do have some conclusions, some indirect indications from other mammals. There are also some social, religious, or issues of culture that hamper us from promoting breastfeeding. Some others tend to believe that, for example, me at the university, I don't even know where breast is located. There was no reference during my medical studies talking about breastfeeding. And I believe probably we are all, let's say, victims of industry. I don't know whether some other reason you wish to add. One thing is for sure, leaving aside the benefits of breastfeeding that you all know and lactation, you should actually see a latest publication of 2017 about holding infants or not, where it can leave traces on their genes. So you see even how we hold our infants might affect the DNA of the infant and having better people, in other words. And as Oscar Wilde used to say, truth is rarely true. So in the case of lactation, we should say that the truth is clear and quite simple for mothers. Probably you're not in the 2% of mothers with true problems of lactation. So continue to breastfeed your children, leaving aside any theoretical danger. Thank you. Thank you very much. That was an interesting speech. We have a few moments for one or two questions addressed to the speaker. Comments of microphone cannot be translated. We should have a microphone circulating in the hall. Otherwise, we do not have any sound in the booth. So the answer to the question is no, these are studies conducted in 2016. So I don't know whether in 2018 we have a differentiation. Still, we have a growing tendency. So if we don't do something about it, we need to find a solution. Now, in these different statistical studies, there are differences between Western societies and other areas. So things are different in the US, in the Western world, different in US, different in Asia. So initially, I will wish to thank you for what you have actually said. What I do want to ask are about the exact thing you just said. Can we have a woman who has normal levels during pregnancy, and due to the drugs that she will actually administer during the pregnancy, her hormones will be affected, and this will actually affect and consequences on lactation itself? Because you said that there is a very, very fragile balance, and when we add such an hormone, the OXT hormone, have you seen any imbalances in the hormones? Now, about OXT, I have never used it. Now, I'm not talking about yourself. When it is administered, OXT, Do you have you ever seen a woman who had a good status to have a hormonal imbalance after the administration of OXT? Well, I don't know whether there's such a study on this topic because nobody actually works on this study. Yes, there are, but there are, let's say, peripheral studies. So gynecologists add OXT and they don't know what happens afterwards. So, as the previous speaker said, we see that there is no synergy between doctors, and this is totally outrageous. We need to have better synergies between different specialties. As I made a recent research, I want to know whether you have such a knowledge. Anyway, thank you very much for your answer. Good morning, thank you. You referred to HIV. A woman after a regular birth who is under administration, can she start breastfeeding 48 hours after she has given birth? I haven't heard something else, but this is something we will discuss afterwards, because up to September 2016, the guidelines from the University of Athens, there were some studies who actually said that there should not be any breastfeeding in HIV women. So there are studies which are ongoing. When a woman is under treatment, they say that she can continue lactation, but I'm not a specialist in HIV. Okay, thank you. Thank you.